with the Arrowhead Area Agency on Aging. And we'd like to welcome you and thank you for joining us for today's session on having the conversation with family and friends regarding advanced planning. We'd like to let you know that the presentation you'll be viewing today was recorded earlier this week due to a scheduling conflict that arose with our presenter. Our speaker had an unexpected and unavoidable commitment that could not be rescheduled, which necessitated recording the session in advance rather than delivering it live as originally planned. We appreciate your understanding of this change in format. Rest assured that the content remains just as valuable and comprehensive as it would have been in a live setting, and the Q&A portion of your submitted questions will still be addressed through follow-up communication. We value your participation, and we hope that you'll find today's session informational and useful. And should you have any questions or feedback after the webinar, please don't hesitate to reach out. So a few housekeeping items as we get started. We are excited to announce that today's webinar will be accessible to a wider audience. We have arranged for ASL interpreters who will be present throughout the session. These interpreters will rotate every 20 minutes, ensuring that everyone can follow the content effectively. And so you'll see at the bottom of your screen, there's an option there for selecting ASL interpretation. And so you can utilize that. If you have any issues with that, please feel free to put that in the chat and Ashley can help you. Additionally, we are recording the entire webinar with ASL interpretation. The recordings will be available on our YouTube channel for later viewing. So whether you attend the session live or you catch up later, you'll have the opportunity to engage in the content in a way that suits your needs. I encourage you to subscribe to our YouTube channel so you can keep up with the latest additions to our video library. We are always looking for ideas for future topics. We're actually right now in the process of getting ready to schedule our webinars for the fall and next winter. So if you've got ideas or suggestions, please feel free to send those our way. You can put them in the chat or you can contact one of us directly. Please keep your microphone set to mute. Just a note, if you experience any issues with your bandwidth or audio quality, it often helps to disable your camera. If you'd like, you can enter your name and your community or your organization you're from in the chat box, what you're hoping to get out of today's session, and how you found out about it. If you have any questions during today's session, please feel free to enter those questions into the chat, and we will coordinate follow-up responses from our presenter via email to all registrants. At the close of today's session, you'll see a quick evaluation of today's session pop up in your browser. Please take a moment to complete that survey. It does help us greatly as we are planning future sessions. One last quick reminder, visit our Facebook page for more information about other upcoming sessions, such as we've got one tomorrow on healthcare directives and one coming up in May on long-term care staffing. You can also check those things out on our website at arrowheadaging.org. So just a few things, first of all, about the Arrowhead Area Agency on Aging. The Arrowhead Regional Development Commission and Arrowhead Area Agency on Aging are designated by the Minnesota Board on Aging as the planning and service area under the authority of the Title III of the Older Americans Act. The Arrowhead Area Agency on Aging is committed to helping older adults maintain their highest level of independence. Area agencies on aging are regional organizations that provide the services, supports, and information for just about everything that older adults and their families might need. Minnesota has 7 AAAs across the state that are local connections for older Minnesotans and the community supports they might need. The Area Agency on Aging's planning and service area is designated by the Minnesota Board on Aging to include Aiken County, Carlton County, Cook County, Itasca County, Coochin County, Lake County, and St. Louis County. And now I'm just going to take a moment to read our Arrowhead Area Agency on Aging land acknowledgement. As we support our mission to help older adults maintain their highest level of independence, we do this while being respectful of the space we are being welcomed into by Indigenous people. We strive to deepen our knowledge and our understanding of the multiple ways in which people see and understand land and acknowledge the Indigenous people who have relationships with this land. We also acknowledge the decades of historical trauma, loss, and grief experienced by Indigenous people. It is our promise to not only recognize these truths, but also to take action to show support of our Indigenous elders, neighbors, and friends, and to understand our place within the past, present, and future of this land. We know that this is just one step in recognizing and honoring the sovereignty of tribal nations. So today's presenter is Sarah Macomber. Sarah Macomber is a geriatric nurse practitioner specializing in neurology at Essentia Health in Duluth, with expertise in Alzheimer's, dementia, and Parkinson's disease. She's also an associate professor at the College of St. Scholastica and a doctor of nursing practice. And she combines her extensive clinical experience with academic credentials. Sarah is dedicated to building long-term relationships with patients and families facing challenges, focusing on helping those families, managing their expectations, and connecting them with community resources. This makes her uniquely qualified to address the complex medical, legal, and emotional aspects of advanced planning. And now we will share that presentation from Sarah Macomber.
Hi, I'm Sarah Macomber. I'm a nurse practitioner at Essentia Health and Neurology Department. I'm also a professor at the College of St. Scholastica. And I was hoping to do this presentation in person, but I ended up double booking myself. So I want to talk to you about how to have effective conversations on advanced care planning, or ACP. And I know that you have heard from several other speakers learning about healthcare directives, about hospice, about death doulas, but sometimes it's really hard to have these conversations. So let's talk about that. And what will happen is if you have questions, we'll have you put them in the chat, and then they will send those to me and I will answer them. I like to say I have no financial disclosures, and I also like to make sure people understand that this presentation is for educational purposes only. I can't comment on specific cases or provide medical recommendations. And I would like to acknowledge that portions of this presentation are from the Conversation Project, and I know that on Getting Your Ducks Together website, they have a link to the Conversation Project, and they have some really, really good resources, and they have guides to help you. So, they also have a slide deck, so I took some of their slides. And the purpose for this session is to really provide all of us practical guidance on how to approach these personal discussions, emphasizing the benefits of openly sharing your wishes. And sometimes that's really hard, and you need to, it's something you have to be thoughtful and think about. So I love this. As I was doing my search for this, I found this quote from Benjamin Franklin from almost 300 years ago. We know 250 years ago, at least. In this world, nothing can be said to be certain except death and taxes. We talk about taxes a lot, but we seem to be quite unwilling to talk about death. And a couple things that I like to talk about when we talk about difficult subjects like talking about advanced care planning and death is we need to think about that it's our experience, we're coming from our experience and perspective, and recognizing that all of us have different experiences and perspectives, and we shouldn't be judging each other, because some of us have been able to have good experiences with death and discussions, and some of us may not have had good discussions. And I also think that you need to recognize for yourself that some of these discussions may be what we call triggering, and that may bring up some old traumas or experiences. So not all of us are going to be able to have that discussion with someone we love. That may not be possible, but maybe what you could take away from this is, one, you're not able to do that, and maybe you can work with someone else who could have that discussion. And I'm going to speak from my experience in education, and it may not work for everyone. And then because you're not here in person, I request that we allow as many people to join the conversation as possible. And so who am I and why do I think this is important? So it's important for you to understand that I was a daughter, I am a daughter, I'm a sister, I'm a wife, I'm a mother, I'm a grandmother, I was a caregiver, and I'm a nurse practitioner focused on older adults, and I'm an educator. I was also very lucky in my family of origin, we talked very frankly from my teen years on about end of life and particularly my parents' end of life preferences and how to support those decisions. And I found out that a lot of families don't talk about that. And I just really respect that my parents were very clear about that and that we talked about it as they aged quite a bit. And also during my 45-year nursing career, I know I don't look like I've been a nurse for 45 years, but I've had a multitude of conversations with colleagues, families, and patients about advanced care planning and the importance of starting the conversation. I've seen it when the conversations have not been done in advance and the difficulties that can develop. So it's really hard. And I think I have a slide coming up talking about that when we have these conversations, it's really about a journey. It's sometimes just taking one small step and not being able to do it all. And I share this picture. This is my dad, Ike Isaacson, and he lived with me, my husband and I, for the last 3.5 years of his life. And he and my mom had been very clear about what they wanted for their advanced directives. And I had to help him go on. He went on hospice per my recommendation. And I thought he would graduate from hospice, and he continued to decline. And it was hard. It was hard to walk with him on that final journey, but it was very clear what he wanted. And we had talked enough and I'd seen him suffer enough so that I was able to support that. But it is hard. And I learned a lot from my parents about the fact that they were very frank about this. And he helped me from a caregiving perspective. It was hard. So, so just take a moment to think about what your experiences have been about having this conversation with people you care about or people, your family. It's hard. Not all of us have had that experience. So the Conversation Project notes that too many people die in a manner they would not choose, and too many of those that matter most are left feeling bereaved, guilty, and uncertain. And what's wonderful about the Conversation Project is it's dedicated to changing the current norm. And that's what I think is so wonderful about this week during National Healthcare Decisions Day, is that we're dedicated to trying at least just having people start thinking about it and start having the conversation. And so why talking matters. We can't plan for everything, but we can share what matters to us with the people who matter most to us. And talking creates the foundation of a care plan built on our values, a plan that will be available when the need arises. And it is hard sometimes to talk about end of life. It's hard to talk about what our values and what's important to us, but it also helps your family members. And so I can't emphasize enough how important it is to have this discussion. So, and this is where I said conversations are a journey, not an ending. So when I first started doing this professionally in my role as a nurse practitioner, I would want to try to get the whole conversation done in one sitting. Well, that's not realistic. You have to realize that it's small steps, and I've had a couple times that I've not done a good job of it, and I've had to step back and start over. So just think about it. And sometimes you might feel like you haven't been successful with your loved one, but you may have gotten some information that you didn't have, and you may have that conversation again later. And so it's even just sometimes talking about it. My husband's family, I don't think both his parents passed away, but they don't really talk about end of life care. And I've had to talk with him a few times, and he can't really express a lot of preferences to me. So he knows that if he isn't explicit about his preferences, that he knows how I'm going to handle him. He says, I know that I'm going to take him off the life support and he's going to be cremated because those are my preferences. But I don't think he's uncomfortable talking about it. I just don't think it's important to him. So starting the conversation. So really evaluate where you are. Is this a time that it's okay for you to have the conversation? Because it's not, there's good and there's bad times. And then evaluate the situation, other people. Is this an appropriate time and place? And in one of the death doula sites that I was looking at that was linked to the Getting Your Ducks Together page, talked about that most of us have a very low death literacy. So most of us have very low understanding and knowledge about end of life. What happens when our life-limiting illnesses or sudden injuries happen to us. So it's okay to say you don't know. I also will tell you that I think a lot of healthcare providers have low death literacy. People don't like to talk about it. It takes a long time to talk about it. And so that's one of the reasons I'm a big fan of hospice, because the people from hospice have a team and they can come in and talk with you. But a lot of times you have to get to hospice. And I think that I don't have a lot of experience with death doulas, but I think that they can also have an opportunity to have an impact. And I have this gymnast on the bar here, because sometimes you feel like you're trying to do it all and it just doesn't work. But you need to recognize that advanced care planning, as I talked about earlier, often requires multiple conversations over time with many fits and starts, and it may not end where you want it to. You might want your family member to be in the same place that you are, and they may not be. And so you have to recognize that this conversation is not so much about you, it's about coming to gain an understanding of what is important to your loved one. So what prevents us from starting the conversation? So a lot of people think they're healthy and they don't need to do it right now. I've also read that people don't want to sign their life away or have decisions made for them. So they have a lack of understanding about what a healthcare directive is. And they think that the healthcare directive takes all their rights away immediately, and that's not true. They don't want to talk with their family about death. It's too difficult of a conversation. And I think, for many years, our society has not been able to talk about death and talk about end of life. We've been focused on extending life. I'm of the generation now, though, where I'm the end of the baby boomers. And so we are going to have to start talking about death more because we are an aging society. Sometimes people have had difficult previous experiences. So they may have been with someone who passed away, or they may have had a family experience that was not good. And so we have to be respectful about that. People don't know how to start it. It's really hard to start it. We also have to recognize there are family and, for many of us, cultural norms. Some cultures do not talk about death or end of life planning, because that's just it. I believe for some cultures, they may think that it brings it on. So you have to be aware of those things. So the thing I like about the Conversation Project is it says the conversation starts with you. So you have to identify what your values are, so our thoughts and feelings and beliefs may not just trip off our tongues or come popping out of our heads. So when someone asks you, what do you want for your end of life care? So though our intentions are good, we really shouldn't be asking someone else what their wishes are if we haven't taken first a little time to articulate what our wishes are. And in doing this reflection for ourselves first, we can gain some insight into the challenges and the opportunities and the blessings that are part of having the conversation. So it's really important for you to be comfortable in your own skin and sort of understand what is important to you and what your values are. Because if you're not comfortable with that, then you're probably not going to be successful with your conversation. So how do you start the conversation? And so we talked about earlier, you really need to have the right time, the right place, and privacy. So you need to think about, is this something that you could do with, say, both your parents, or would you want to do it with just one of them? You will need to allow privacy because people don't always want to talk about this. And this is a very private thing. And from some of the reading that I've done, sometimes you can talk about, come at it. I would say that this is not always a good topic to come at directly. It sometimes is better to come at it more indirectly or from the side. I think saying that you're concerned about or you're curious about, and you could talk about maybe there's been a recent movie or an event to prompt the discussion, or share a recent experience. Maybe someone that you and your loved one knows recently passed away, and it either was a good experience or it was a difficult experience, but maybe using that as a prompt. Another thing you need to do is seek permission to discuss, because I've had this problem where I've pushed the conversation, and you really need to step back. So if there's reluctance, explore that. And then it sometimes helps to talk about your own thoughts and preferences that you have identified. Like, I've identified that I don't want this to happen, or I've identified this to happen. But you may need to, just even bringing the topic up can be triggering. So just even bringing it up the first time is something important to talk about. And we talked about starting with small steps. You might have a really high mountain to climb, but be happy with that one small step. And then make sure that you're using terms that the person can understand. And because I work with people with cognitive impairment, really consider undiagnosed cognitive impairment. And because you may be talking about things that you understand, like talking about quality of life or life prolonging treatments, and the person may not understand that. So that's important. So there's also a project, and I have it on my reference list, that we are using at Essentia, and it's a process of, it's called the Serious Illness Conversation. And these are just a couple quotes from it. One is, as the provider, but you could do this as a family member, I would like to talk together about what's happening with your health and what matters. Would this be okay? And so that's the asking the permission. And the other question is how much information about what might be ahead with your health would be helpful to discuss today? So sometimes people don't want to know all the bad parts. And so you have to be careful about what you say to them. But I think you could frame it in that, I'm concerned that if things get worse, I need to understand. I need to know what's important to you, what you want to have done. So what's not to do? I already told you, being pushy, rushing your agenda. So I think I've had that happen a couple times where I've done that with patients, partly because we should have had the discussion a long ago and their family should have. It hasn't happened. I really get frustrated also when people use what I call scary terms. So I sometimes hear people, when they talk about resuscitation and CPR, they say, well, you don't want them to break your ribs. Well, nobody wants their ribs to be broken. That's not what we're talking about. If you start to talk about CPR or being resuscitated, you need to talk about how that can be helpful and how it might not be helpful, and be more clear about it, and not stopping talking when people give you the signs or tell you to stop. So sometimes people, will kind of like withdraw, or they will not answer, or they won't look at you. And I keep going back to this, taking small steps, do that. And not recognizing, I don't know how that got to be recognizing that previous life experiences and trauma may not allow a person to make any further decisions. There are a lot of people that have had really bad experiences with death, and we need to recognize that. support that person. And then also recognizing the person that does not have the capacity to understand or have the discussion. So you've started. So what are you to do next? So I always am probably I'm the biggest fan of working to identify a healthcare agent or proxy. If I can't get anything else done, I really talk about, so if you became unable to make decisions for yourself, who do you trust and who do you want have make? So if you can get nothing but that done, that is a wonderful, wonderful option. And that if that's all you can do, that's great. That's awesome. There also are a couple of, and I'm not going to click on it in Zoom because it's hard to get back to the original place. There's a conversation starter guide or the condensed guide that are in the from the conversation project, and they really kind of take you through that. And it's really nice. I like the condensed guide because it's 2 pages. The other one is like 8 or 12 pages. And I want to go back to the healthcare agent or proxy. The Minnesota one, I think, is like 6 to 7 pages long. And a lot of people that is too long for. And we do have a short form, so you can do that. It's 1 page. And recognize when you're starting this, that this can be an overwhelming topic for many of us. And allow people the time to think and really allow for different values than your own. Each individual's experience and journey is unique, and we have to allow space for those differences. And that's really hard. So I took this from the conversation project. I really like this about how to do discussions. So you see here first, and at one area they have, you have healthy life. This is healthcare trajectory, end of life, and then ongoing conversations and documentation. And so the first thing is to, like I said, name a healthcare proxy. My son, when he was 18 and he went in the National Guard, he had to do a healthcare directive because the military said, you need to have this if you get activated and sent overseas. Then as your health declines, or as early in life as you're willing to talk about it, is complete the conversation starter guide, talk to your family. And then as having a serious illness conversation with your clinician as your health is getting more impaired. You don't need to do that when you do the healthcare proxy, depending on how bad your health is. And then you need to complete a POLST with a clinician as things are getting more towards the end of life. And then there's the end of life talk. And I'm not sure if Kristen has reviewed a POLST. A POLST is something called Physician's Orders for Life-Sustaining Treatment. And what that means is when you have a healthcare directive, you might say, I want to be a do not resuscitate. On that, so I will talk to people who are more advanced in their illness, and they'll say, yeah, I want to be a do not resuscitate. And I have that in my healthcare directive. And I say, well, if you don't have a signed medical order from a provider,
We may be having some technical issues here.
So I think this is a really nice diagram and its picture. I love it. So the other thing is, once you have started the conversation, once and done is not enough. So I see families struggle a lot of times because they may have had a discussion 4 or 5 years ago, and then somebody's health really declines and they haven't talked about it regularly. And so you need to me, this is kind of like when you do your taxes annually, or you should kind of like have a check-in. And the other problem is we have healthcare technology changes. And as our personal health and abilities change, it is important to continue discussions. So for example, I've always said, I don't want to be resuscitated. I've learned about a breathing support technique called BiPAP, where they don't put a tube in, but they support your breathing by pushing air in. And that might be something I would consider. But I think those are things that you have to think about. You also have to have regular conversations to help reinforce goals and preferences of care. It is never easy to facilitate the difficult decisions for another person. Thinking back to my dad, he had a series of hospitalizations before he died, and went on hospice. And one of the times he was in the hospital, he had pneumonia. And my younger sister came and was spending some time with him in the hospital. And I wasn't able to be there. But I had a discussion with her. I said, I want to remind you, and we talked about this as a family, but she wasn't with him day to day. She lived out of town. And I said, I want to remind you that Dad is a do not resuscitate. There is a medical order here written here. And so older people who are 89 years old and have pneumonia can stop breathing. And I just want you to remember that these are his wishes. So he would not be treated. And I think she was kind of startled that I had that discussion, but I felt it was important for her to be aware so that she could honor his wishes. So often there are family disagreements. So families have different ideas about what should and shouldn't happen. So family meetings and discussions early and often help to discuss disagreements about healthcare choices. And, it's really not about it's not about what I want, it's about what the individual's preferences and choices are. So I might not agree with those choices, but if that's what they wanted, then it's important to honor those choices. And that's where the role of the healthcare proxy is to facilitate and implement the individual's preferences. And getting the differences on the table early helps to address those disagreements. And sometimes different disagreements are often related to past experiences or expectations. So somebody may be upset that they're not the healthcare proxy. Somebody may have had a bad experience with a death in their an extended family or a friend. And so there's a reason that we have those different perspectives. So it sometimes helps to have a family meeting and talk about that. So one thing I want to tell you is Medicare does reimburse for advanced care planning. You can ask your healthcare provider if they can help you with healthcare providing planning or provide direction where to go. So at Essentia, we have a advanced directive. We have a health advanced care planning program. And so at most of the neighborhood clinics, there are registered nurses that can help you complete a healthcare directive. You can also request an appointment to meet with a facilitator for advanced care planning. So for example, I'm an advanced care planning facilitator, so I do that in neurology, and your provider can do that. I can also tell you that many providers are uncomfortable talking about advanced care planning. Number one, it takes time and they don't have time. And number two, the research has shown that doctors, particularly doctors, overestimate the health status of their patients. And if they were asked to predict who might pass away in the next year, they overestimate that. So it's a hard thing. And so not all healthcare providers are good at that. So now I would hopefully Brenda will help you with some questions and answers. I would just like to leave you with a couple of thoughts. One, approach this gently. Don't push it. The other thing is be respectful of people, and sometimes you have to practice. So sometimes you have to practice what you're going to talk about. So good luck, and I will be more than willing to answer questions. So did I do okay?
All right. Well, thank you, everyone. I'm going to take and stop sharing real quick and switch us over to, since we do have a little bit of time, sharing some information about what we have for resources available from the Get Your Ducks in a Row campaign that Sarah mentioned. We have all of the things that she talked about. So the items of the Conversation Project, we have available on our tab on the resources to explore. So you can go through, and each one of these headers is a link to a different resource, including things on having the conversation, on just general advanced planning, some information on power of attorney, on transfer on death deeds and things like that. Some things that are specific to advanced planning in terms of a dementia diagnosis. And so lots of good stuff on there. We also have coming up throughout the region, we have community advanced planning workshops going on that you can find out about. Our first one's coming up here on May 7th in Duluth, and we've got them going all the way through October. So you can take a look on there, and we've got 25 spaces for each of those workshops. Those workshops will be 2 hours long, and there'll be a short, about a half-hour presentation on healthcare directives and on power of attorney at each of those sessions. And then the rest of the time is really going to be dedicated to answering your questions and helping you go through and workshop and actually work on your documents. And you could actually complete your documents during the course of that workshop. And so it's a really good opportunity. We're going to provide lots of resources and copies of all of the documents that you might need for that. So other things that we have on there, we've got our educational webinars. We've got, besides the one today, and we did have two others this week, you can find out about, we've got one tomorrow on healthcare directives. Also, all of the webinars from this week will be posted on the website, so you'll be able to go back through and view those again or share those with friends and family. All sorts of good opportunities there. Yeah, so we've got, along with the webinars that we're presenting as part of this campaign, we also have a full series of webinars. Ashley and I work to put on at least one webinar, educational webinar every month during the year. And so, as I mentioned, if you've got questions about various topics that you'd like us to do, we're happy to take suggestions. And you can learn more if you go on the arrowheadaging.org website about what things are coming up. We also have, on top of the webinars that we produce, we also have ones presented by Senior Linkage Line on Medicare counseling, on scams, on all sorts of different topics. So I think that's about all we have for today. Thank everybody for joining us today. Ashley, anything else we need to mention before we let folks go?
I don't believe so. Kathy did have a question about the DNR and the polls. Kathy, if you want to explain more, you can come off mute. Otherwise, if you want to send an email, I can try to reach out to Sarah too and make sure we can address that question, because she's probably more knowledgeable in that than I am.
Just the question was, when the video paused, she was about to say the difference between having a DNR and a pulse. And I understand the pulse is where the physician specifically fills out the form for a do not resuscitate. But I'm wondering if she mentioned the DNR, that how it affects if paramedics come to the house, or, first responders. That's always a gray area up in northern Minnesota. So that was my question.
And the pulse is not specifically just, DNR is specific to whether or not the resuscitation and intubation, but the pulse includes more than that. And it's physician's orders for any care, what care you will receive, want to receive, and don't want to receive at the end of life. But we can, and I did put a link in the chat to the Minnesota Medical Association's information on provider orders for life-sustaining treatment, or POLS, as they're called. But we can also run that through Sarah and get back to you.
All right, thank you.
Yeah.
Other than that, I did put up tomorrow's webinar that Brenda discussed about healthcare directives, and then we do have another one coming up in May as well. But otherwise, I think if anybody doesn't have any more questions, we can give you back the rest of your day. Thank you all for joining us. Have a good day.
Thank you.
Thank you. Thank you.